You've lived with your condition for years. Maybe it's hypothyroidism, maybe it's high blood pressure, maybe it's type 1 diabetes or epilepsy, or a genetic trait like sickle cell. But the second you saw that positive test, your condition started to feel 1,000 times bigger. The question that drowns out every other thought is simple and terrifying. Will this hurt my baby? I know why you're anxious. I also know how to help you breathe again. Take a slow inhale with me. Exhale. As a maternal-fetal medicine specialist, I care for patients with pre-existing conditions every single day. And here is the truth I want you to hold on to from the very beginning. A pre-existing condition is not a guarantee of a complicated pregnancy. It is a roadmap. It tells us exactly where to pay attention, what to measure, and how to act early so that you and your baby are protected. When we follow the roadmap, outcomes are overwhelmingly good. Before we go deeper, let me promise you what these minutes together will give you. We're not going to list 100 diagnoses and leave you swimming in jargon. Instead, I'm going to hand you a clear framework you can use for any condition. Chronic illnesses you actively manage, and genetic traits you carry without daily symptoms. I'll show you how to organize your care, what to do first, how to partner with your personal medical team, and how to translate fear into step-by-step actions. The message all the way through will be the same. A well-managed condition leads to a healthy pregnancy. Let's turn uncertainty into a plan. To make a complicated subject simple, I use a 2 buckets framework. Imagine every pre-existing issue you've heard about falling into one of 2 containers. The first bucket is what I call management conditions. These are ongoing illnesses where your body's baseline is different and needs active adjustment during pregnancy. Think hypothyroidism, type 1 or type 2 diabetes, epilepsy, chronic hypertension, lupus, kidney disease, inflammatory bowel disease, or severe asthma. The theme in this bucket is deliberate, ongoing management. You and your clinicians will be checking levels, tweaking medications, watching trends, and preventing flares. The second bucket is awareness conditions. These are traits or carrier statuses that usually don't affect your day-to-day health, but do tell us something important about the baby's possible risks. Think sickle cell trait, cystic fibrosis carrier status, spinal muscular atrophy carrier status, thalassemia traits, or certain clotting variants your family might carry. The theme in this bucket is information, screening, and preparation. We use knowledge to guide testing, counseling, and, when needed, special monitoring for your baby. Let's spend time in bucket 1, because this is where most of the worry lives, and where most of the wins happen. I'll walk you through a 4-step playbook using hypothyroidism as a concrete example, and I'll weave in notes for other conditions, so you can see how the same structure applies. Step 1 is the preconception visit whenever possible. If you're planning pregnancy, book time with the specialist who manages your condition, your endocrinologist for thyroid or diabetes, your neurologist for epilepsy, your rheumatologist for lupus, your cardiologist for heart disease, alongside your OB/GYN or midwife. The goal is stability first. For hypothyroidism, that means aiming for a TSH in the pregnancy range before you conceive, typically around the lower half of normal. For diabetes, it means optimizing your A1C and time in range to minimize early miscarriage and reduce malformation risk. For epilepsy, it means confirming you're on the safest effective anti-seizure medication and supplementing with a higher dose of folic acid if your neurologist recommends it. For chronic hypertension, it means reviewing your blood pressure medications. Some drugs are safer in pregnancy than others, and targeting a healthy blood pressure before conception. This visit is also where you review all medications and supplements, update vaccinations, screen for anemia and vitamin D deficiency, consider genetic carrier screening if it hasn't been done, and discuss a healthy weight and exercise plan tailored to you. If pregnancy wasn't planned, or if you're already pregnant by the time you are watching this, don't worry. We move to step 2 now. Step 2 is the immediate phone call. The day you see a positive pregnancy test, call the specialist who manages your condition and your OB/GYN or midwife. Why immediately? Because pregnancy changes physiology right away. Using hypothyroidism as our example, your body's thyroid hormone needs increase as early as the first few weeks. Thyroxine supports early placental development and your baby's brain formation long before your baby's own thyroid is working. In many patients with hypothyroidism, we increase levothyroxine by about 25–30% as soon as pregnancy is confirmed, and we draw labs early and often to fine-tune the dose. That adjustment protects neurodevelopment. In diabetes, insulin requirements can fluctuate in the first trimester. we check your sugars closely and adjust your insulin or other therapies while nausea, appetite changes, and hormones are shifting. In epilepsy, we check anti-seizure medication levels early and schedule a monitoring plan because blood volume and metabolism can change drug concentrations. The safest level is the level that prevents seizures with the lowest effective dose. In chronic hypertension, we confirm you're on pregnancy-safe medications and set blood pressure targets. For many patients, we also plan to start low-dose aspirin later in the first trimester if you meet criteria to reduce preeclampsia risk. Whatever the condition, that first phone call is about getting your management adapted to pregnancy quickly, not later. Step 3 is assembling your A-team. A team is a perk, not a penalty. Your core team will include your OB/GYN or midwife, your condition specialist, and often a maternal-fetal medicine specialist, someone like me, who helps coordinate the big picture. Add in a registered dietitian experienced in pregnancy when nutrition is central to your care, like with diabetes, celiac disease, or inflammatory bowel disease. Add a mental health professional if anxiety, depression, or trauma are part of your story. Mental health is health, and treating it safely improves outcomes. If you have a cardiac or renal condition, your cardiologist or nephrologist becomes a key player. If you have lupus, your rheumatologist stays closely involved. If you have asthma, your pulmonologist helps keep your lungs quiet. You are not more high risk because more people are helping. You are more known. Your job is to be the captain. Keep a simple list of who's on your team, what each person is responsible for, and how to reach them. Step 4 is the mindset shift I want you to anchor. Medication, when indicated, is protection, not a threat. I hear the same fear from many patients. Will my medication hurt the baby? For conditions like hypothyroidism, diabetes, epilepsy, severe asthma, lupus, or chronic hypertension, undertreatment is what raises risk. In hypothyroidism, too little thyroid hormone can raise the risk of miscarriage, preeclampsia, and developmental concerns. Taking levothyroxine to keep TSH in the target range is how you prevent those risks. In diabetes, high blood sugar early in pregnancy increases the chance of congenital anomalies and later complications. Using insulin or other safe therapies to achieve healthy targets is how you protect your baby. In epilepsy, uncontrolled seizures are dangerous. Staying on the safest effective anti-seizure medication with close-level monitoring is how you protect your baby. In asthma, poor control leads to low oxygen levels. Taking inhaled steroids as prescribed is protective. In lupus, flares during pregnancy can be serious. Staying on pregnancy-compatible suppressive therapy like hydroxychloroquine reduces flares and improves outcomes. The principle is universal. Stabilizing your condition creates the safest environment for your baby. You and your specialist will always choose the lowest risk, most effective regimen. Never stop a medication on your own. Let's make this even more practical by mapping the rest of a typical pregnancy for management conditions. In the first trimester, you'll likely have early labs tailored to your diagnosis, thyroid function every 4 to 6 weeks in hypothyroidism, frequent glucose reviews, and A1C in diabetes. Drug levels for anti-seizure medications, kidney and liver panels, and disease activity markers in lupus, baseline urine protein and kidney function for hypertension. This is also when we discuss low-dose aspirin if you meet criteria to reduce preeclampsia risk, and when we plan early ultrasounds for dating and viability if your condition carries an increased risk of congenital heart disease or other anomalies, such as diabetes with elevated A1C at conception or certain anti-epileptic medications. Your MFM will schedule a detailed fetal anatomy scan and sometimes a fetal echocardiogram later in the second trimester. We'll also talk through nutrition and weight gain targets that reflect your condition and your body. For diabetes, you'll likely learn or review home glucose monitoring and meal planning. For celiac disease, you'll confirm your gluten-free diet meets pregnancy needs. For kidney disease, you'll monitor protein and blood pressure closely. For lupus, you'll do extra scans if you carry anti-Ro SSA or anti-Ley SSB antibodies to watch the baby's heart rhythm. In the second trimester, your program continues with a predictable rhythm. Thyroid labs remain every 4 to 6 weeks. Diabetes management shifts as insulin resistance increases. Hypertension targets are reviewed at each visit. Asthma control is assessed regularly. You'll have the standard anatomy ultrasound around 18 to 22 weeks, and depending on your diagnosis, additional growth scans about every 4 weeks thereafter. You may have periodic non-stress tests or biophysical profiles in the third trimester if your condition or medications warrant extra fetal surveillance. If you're on medication conditions that can affect fetal growth or the placenta, we watch growth patterns and fluid levels more closely. Throughout, every visit is a chance to ask, what is our target, how are we trending, and what is our next step? Now let's switch to bucket 2, the awareness conditions where your health is typically stable, but your carrier status or trait gives us important information about your baby's potential risks. We'll use sickle cell trait as our case study, and the steps apply equally well to cystic fibrosis carrier status, spinal muscular atrophy carriers, thalassemia traits, and other inherited conditions. Awareness conditions begin with one powerful truth. Carrying a trait is not the same as having the disease. If you have sickle cell trait, you carry one copy of the gene. You are usually healthy and may never have symptoms. If you are a cystic fibrosis carrier, your lungs and pancreas function normally. You carry only one gene. The reason we care is simple. What matters for the baby is whether your partner also carries a relevant gene. So step 1 is partner screening. If you know you are a carrier for any condition, the first and most important next step is testing the baby's other biological parent. This is usually a simple blood or saliva test. If your partner is not a carrier, your baby's chance of having the disease is essentially 0, although there's a 50% chance your child will also be a carrier like you. If your partner is also a carrier of the same condition, your baby has a 1 in 4 chance of having the disease, a 1 in 2 chance of being a carrier, and a 1 in 4 chance of inheriting neither gene. That is when step 2, genetic counseling, becomes invaluable. A genetic counselor is a specialized clinician who will sit with you and translate odds into options in plain language. They will discuss diagnostic testing options during pregnancy, like chorionic villus sampling in the first trimester or amniocentesis in the second, as well as non-invasive screening where appropriate. They will also talk about postnatal testing, newborn screening, and what early treatment looks like if a condition is identified. This meeting is not a trap or a judgment. It is a safe space to gather information and make choices that fit your values. Step 3, in awareness conditions, is deciding how much information you want and when. Some families choose diagnostic certainty in pregnancy. Others prefer to wait for newborn screening and postnatal testing. There is no single right choice. Your medical team will walk you through risks, benefits, and timing. Step 4 is remembering that even in awareness conditions, your standard pregnancy care remains the same unless a diagnosis is confirmed. You still receive routine ultrasounds, routine labs, and routine vaccinations. You still focus on healthy nutrition, movement, sleep, and mental health. Information is power because it allows preparation, choosing a hospital with the right specialists, arranging early pediatric care if needed, and building your support system without panic. Regardless of your bucket, there is a universal empowerment toolkit that will serve you throughout pregnancy. First, I want you to reframe the words you use. Many patients hear high risk and feel branded. I prefer highly known. Highly known patients are not walking complications. They are patients we can care for with precision. We are not guessing. We are measuring, tracking, and acting early. The more we know, the calmer and better your care becomes. Second, embrace your role as the world's leading expert on your own body. You live with your condition. You know your baseline. When something feels off, symptoms creeping in, side effects rising, fatigue out of proportion, say it out loud. Your voice is data. Your team needs it. Third, organize your care so it feels manageable. Keep a one-page summary. Your diagnoses, medications with doses and timing, allergies, the names and phone numbers of your clinicians, your target ranges, for example, TSH goals, blood pressure goals, glucose goals, and the schedule of upcoming tests and ultrasounds. If you monitor at home, blood pressure, glucose, peak flows, write down your numbers or use a simple app so you can show trends at visits. Fourth, adopt a few daily anchors that support nearly every condition. Regular balanced meals with protein and fiber to steady energy and blood sugar. Gentle, consistent movement most days, like walking after meals or prenatal yoga. A sleep routine that protects 7 to 9 hours as best you can. And simple stress supports, whether that's a breathing practice, short mindfulness exercises, time in nature, or brief check-ins with a trusted friend. These are not luxuries, they are therapies. Fifth, understand the red flags specific to you and the universal ones for all pregnancies. Universal reasons to call promptly include vaginal bleeding that is heavy or accompanied by pain, a sudden gush or steady leak of fluid, severe headache or vision changes, right upper abdominal pain with nausea, persistent vomiting and inability to keep fluids down, painful contractions at regular intervals before 37 weeks, fever, new shortness of breath at rest, and decreased fetal movement in the third trimester. Condition-specific red flags might include sustained blood pressures at or above thresholds your clinician gave you, repeated high glucose values despite adjustments, seizures or auras, chest pain, swelling that feels very different from normal pregnancy swelling, dark urine or reduced urine output in kidney disease, or signs of a disease flare. Ask your team to write your top 3 call us now signs on your summary sheet and keep it handy. Sixth, remember vaccinations and preventive care. In most pregnancies, flu vaccine, Tdap, and other recommended vaccines protect both you and your baby. Timing can vary with certain immune conditions or therapies, so confirm your plan with your specialists. Seventh, think ahead to delivery. Having a management condition does not automatically dictate how you give birth. Many patients with well-managed conditions labor and deliver vaginally. Some will have medical reasons to plan an induction or a cesarean. The key is alignment, your preferences, your condition, your baby's well-being, and your team's recommendations, all in conversation, never surprise. Ask early. Under what circumstances would we consider early delivery in my situation? What monitoring will I have in labor? If I need a cesarean, how will we manage my medications and recovery? Knowing the if-thens reduces fear. Eighth, look beyond birth. Postpartum is a time of big hormonal shifts, sleep disruption, and new routines. Almost every management condition needs a postpartum plan. Thyroid hormone needs can drop back toward pre-pregnancy levels. Schedule lab checks and dose adjustments. Diabetes regimens change immediately after delivery. Make sure you have clear instructions and supplies before leaving the hospital. And schedule your postpartum glucose testing if you had gestational diabetes. Hypertension may improve, or it may spike in the first 2 weeks postpartum. Keep your cuff and call for high numbers. Lupus and other autoimmune diseases can flare. Have follow-up with your rheumatologist on the calendar. Many anti-seizure medications need level checks postpartum as blood volume and metabolism normalize. Breastfeeding is possible for many patients with chronic conditions, and many medications are compatible with lactation. Run your drug list past your clinicians so you can feed your baby the way that works for you. And finally, guard your mental health with the same seriousness you guard your labs. Postpartum depression and anxiety are common and treatable. If you feel persistently sad, anxious, irritable, hopeless, detached, or if intrusive thoughts scare you, tell someone on your team immediately. Getting help is an act of protection for both you and your baby. Let's pull this together into a simple, actionable checklist you can take to your next appointment. First, name your bucket. Are you in management, awareness, or both? Second, map your team. Who is on it? What is each person's role, and how do they communicate with each other? Third, confirm your targets. What are the numbers we are aiming for? TSH, A1C, fasting and post-meal glucose ranges, blood pressure goals, drug levels, disease activity markers. Fourth, schedule your monitoring. How often are labs, ultrasounds, growth scans, non-stress tests, drug levels, and clinic visits? Fifth, list your medications with doses, timing, and what to do if you miss a dose. Confirm which are pregnancy and lactation compatible and what adjustments we anticipate postpartum. Sixth, clarify red flags. What are the 3 things specific to your condition that should trigger an immediate call, and what are the universal reasons to seek care? Seventh, plan for delivery. What would prompt an induction or cesarean in your case? What monitoring will you have in labor, and what is your postpartum medication and follow-up plan? Eighth, decide on genetic screening or diagnostic testing if you carry a trait, and if needed, arrange partner testing and genetic counseling. Ninth, protect your daily anchors, meals, movement, sleep, stress care. 10th, decide now who your one, always answers person is outside the hospital, someone you can text when you feel overwhelmed, to remind you that you are not doing this alone. You are not broken. You are not less than. You are someone who already knows how to live with a condition and advocate for your own health. That experience is not a liability in pregnancy. It is an asset. You are starting this chapter with more knowledge and more support than most people ever have. Your body has carried you this far, and with the right partnership, it is more than capable of carrying this baby. When fear starts to rise, when the what-ifs get loud, Come back to the roadmap. What bucket am I in? What is my target? What is my next step? Fear thrives in vagueness. Confidence grows in specifics. I want to say this clearly, because it matters. Your medical team is your partner. Every decision about medication, testing, and timing belongs to that partnership. Bring your questions. Ask us to explain the why behind every recommendation. Tell us when something feels off or when a plan doesn't fit your life. We would rather adjust early than rescue late. You are the most important member of your A-team, and your instincts are data we rely on. If you are on this journey with a pre-existing condition, I hope you can feel your shoulders drop a little right now. You have a framework, you have a plan, you have a voice that matters, and a team that wants to hear it. A well-managed condition leads to a healthy pregnancy. Again and again, that's what I see in clinic, on ultrasound screens, and in delivery rooms. You can do this. You are doing this already. If you feel comfortable, I'd love for you to share one piece of advice or one moment of reassurance you've received that helped you manage your condition during pregnancy. Maybe it's the checklist you keep on your fridge, the question that changed your care plan, the way you learned to time your medications, or the mantra you repeat before appointments. Your experience may be exactly what someone else needs to hear tonight. Thank you for spending this time investing in your health and your baby's health. Take one more deep breath with me. In and out. You are highly known, well supported, and you have a clear roadmap forward.